Hello students, today we'll discuss a topic which is very interesting and very common, especially in young individual, a vascular disease. And for undergraduates, it is kept as a long case and commonly a long question also, and lot of MCQs have asked. And other than atherosclerosis, which is a very common cause for vascular block, arterial block in specific, next known entity, common entity or should be known entity is TAO in short, otherwise thromboangiitis obliterans. THROMBOANGIITIS obliterans. Double I is there, not single I. There's a point spelling I want to just highlight that point. So it's also called as Buerger's disease because the disease is eventually identified and formulated by Leo Buerger earlier. So it is named after him. It is a non-atheromatous disease. Mainly medium-sized vessels are involved and segmental. One segment will be used and other segment will not, like this. Segmental, suppose this is the vessel. This part is used, involved. This part will be involved. There will be gap here. Unlike in atherosclerosis, there won't be gap. It will be diffused like this. Where here, like this, there will be gap. So it is segmental. So non-atheromatous, segmental, mainly medium-sized vessels are involved. Unlike in atherosclerosis, large vessels and distal vessels are involved, like aorta, femoral artery, ilioquemoral, subclavian artery, carotid artery, and so on. So whereas it is the medium-sized vessels are involved and segmental. Initially artery, then vein, then nerves are involved. So eventually neurovascular involvement occurs. So there is a point which you have to remember. It's an inflammatory disorder, non-atheromatous. That is a very important point which you have to remember. Segmental, again progressive. That is also very important. And involving medium-sized and small distal vessels. And I'm going to tell type 1 and type 3 collagen. There will be micro abscess formation, giant wells or skip lesion. That is the most important thing you have to remember. Skip lesion, like this. So this is the skip lesion. And it's common in males, although exclusively in the males. Rarely females are involved. So there is some hormonal relation is there. It is seen mostly in smokers. It's uncommon in non-smokers or tobacco chewers. So exclusive disease of smokers or tobacco chewers, specifically in males, uncommon in females, and interestingly occurs in younger age group, usually below 40 or 45 years, uncommon to develop after 45 years. If somebody develops peripheral vascular disease, arterial disease, at the age of 55, we always consider it as atherosclerosis, the prime cause. Whereas if somebody develops such disease in a smoker, young male, maybe 28, 30, 35 years, then first diagnosis comes TAO prior to atherosclerosis. So that's how exactly it's a biological behavior or pathological nature of the disease, and disease usually begins in the lower limb. One side first, eventually other side, and eventually later involves the upper limb. When disease progresses, it's a progressive disease, and interestingly, abdominal vessels involved get very late. Other vessels get involved later, very late. Unlike atherosclerosis involves simultaneously many vessels: lower limb vessels, upper limb vessels, aorta, mesenteric vessels, celiac vessels, and so on. Everything can get involved. So it is not that common involvement. So specifications are there when disease is involved exclusively in the scope in smoker. I already told that. So it's a disease commonly in the young and middle-aged age. I have already told. It's more common in Israel, Japan, and India. It is quite common. It is in South Asia, Asia. It is very common. In lower socio-economic group, it is very common. Probably barefoot walking, minor feet injuries are quite common. In the lower socio-economic group, there is probably the reason. All those things are, I'm not much interested, but genetic relation is there. Maybe these things are useful as far as MCQ is considered, which HLA antigens are involved in developing TAO and which socio-economic group it is involved, and males are exclusively involved. All those specific points always remember when somebody discusses about the TAO or thromboangiitis obliterans. So I'm not going to discuss, of course, I just highlight here smoke, contains carbon monoxide and nicotinic acid, and it causes intense vasospasm initially, vasospasm of the medium-sized arteries, and eventually intimal hyperplasia. You know that intima media adventitia is there. 3 layers are there for the artery. So intimal hyperplasia develops, and once hyperplasia develops, blockage occurs, then thrombosis occurs. So vasospasm, intimal hyperplasia, blockage, and then thrombosis, then occlusion. You know that there is 2 terminologies you have to remember in arterial diseases, basic terminologies. One is occlusion, second is stenosis. Occlusion is complete block by principle. Stenosis is partial block, there is still flow. So in such a fashion, if there is a femoral stenosis, femoral artery stenosis, if you place your fingers, you'll be able to feel a thrill. If you auscultate over the femoral, you'll be able to hear a breathe, because there is a turbulence. Whereas even there is a complete occlusion, there is no flow, no thrill, no bruit, no palpable pulse. So that's the difference between the 2 pathological condition, pathological nature, not condition, nature of the arterial disease. That's important. Occlusion and stenosis. And panarterial disease, this is very specific. Panart, all layers are involved. Mainly segmental, I have already told. Eventually artery, vein is involved. Eventually nerves are involved. Vasa, nervorum is involved. At that stage, they will develop rest pain. And once a complete blockage occurs, what happens? Usually what happens, if this is the main vessel, if this is the main vessel, I said this is the blockage, this is the blockage, this is the blockage, I already told segmental. All people will have collaterals to compensate, like a bypass road it is. If the main road highway is blocked, so need to go through the bypass or smaller routes to reach the other side. So this is there, facilities are available everywhere. Same thing here in the body also. Main artery is blocked. You've got collaterals, small vessels, which usually may not function optimally, because there's no need to function, because main vessel is functioning well. But when it is blocked, like in TAO or in atherosclerosis, collaterals will open, this will open, collaterals will open. And once these collaterals open, what happens? It increases, it widens, and it takes up the perfusion, because main vessel is blocked. So this perfusion comes, blood circulates and reaches the distal to the block. Distal to the block. So this is called as distal runoff, or perfusion of the main vessel, or blood supply of the main vessel distal to the main block through collaterals happens. And so whatever ischemia which has developed is compensated, and perfusion is maintained distal to the obstruction through collaterals, where collateral get opened adequately and functions adequately. So this is called as compensatory peripheral vascular disease. It is acceptable because still perfusion is adequate. Patient don't feel any, initially might feel the ischemic features, eventually it is compensated. Also it is called as functional limb ischemia. Pathologically it is compensatory peripheral vascular disease. I'll repeat: main block, vessels in the medium-sized vessels, multiple blocks, and distal to the block, perfusion is reduced, then collaterals will open, it will take up the perfusion, maintains the perfusion distal to the block, distal to the distal moat block. So distal runoff, radiologically or angiogram wise, it is called distal runoff. So adequate perfusion occurs through collaterals, and ischemia which is developed by blockage of the main vessel is compensated. That's what is called as compensatory peripheral vascular disease, also clinically called as functional limb ischemia. Now what happens if disease progresses? Suppose patient continues to smoke, he refuses to stop smoking, and disease progresses further to the collaterals. Now that is the worst part of the situation. The disease develops here in all these collaterals, and there are no enough collaterals in the collateral to perfuse the limb distal to the main obstruction. In collaterals also significantly blocked by the disease progression, then no more adequate perfusion is possible in the distal area, especially in the limb, maybe foot or lower leg, and it becomes a decompensatory peripheral vascular disease. Whereas in this situation, um, radiologically, if you look into that, distal runoff or perfusion distal to the block is totally inadequate, and ischemia develops, and they will have a decompensated limb ischemia or peripheral vascular disease, where this is called as critical limb ischemia. They will have rest pain, severe pain, they're not responding to any analgesics, and their toe pressure, ankle pressure will be reduced. ABI index also will be reduced. So ABP, ankle brachial pressure index also will be reduced. ABPI also reduced, and so go for a critical limb ischemia. It's very, very difficult to treat such patient. In due course of time, they will land with the different levels of amputation, maybe below knee, maybe above knee, or at least toe amputations, and so on. So stopping smoking is important. So 2 levels of disease progression pathological, which you have to remember: main vessel involvement, segmental involvement, and skip lesions. And once it is involved, ischemia develops, collaterals open up, they takes up the function, and ischemia compensates, functional limb ischemia. And collaterals also diseased, and there is no adequate enough collaterals, then collaterals also get blocked, and so there is no adequate perfusion at all distally, and ischemia worsens, decompensatory peripheral vascular disease, causing, most importantly, what is called as critical limb ischemia. It's a very commonly asked MCQ question, short note, viva they will ask. You should be able to define critical limb ischemia always. So functional limb ischemia, critical limb ischemia, rest pain, reduced toe pressure, reduced ankle pressure, ankle brachial pressure index less than 0.3, and severe pain, persistent pain, and which will not respond to any analgesic or NSAIDs, is the correct definition of the critical limb ischemia. So this is what exactly I already told: rest pain, ulceration, gangrene. I also told the definition. Already I explained what is the meaning of decompensatory peripheral vascular. It's very, very important. They both are same. This cause of this clinical entity. This is the pathological entity. This is the pathological entity. This cause of this clinical entity. Remember. And so all these things are this is what exactly happens. It's called panarthritis. That is, this word is important. There will be migratory superficial thrombophlebitis. Vasa nervorum is involved, and this leads into rest pain. And arterial lumen is blocked, but not thickened. That is important. In atherosclerosis, it is thickened like this. If this is the vessel, it is blocked like this. Whereas in atherosclerosis, it is thickened like this. So this is the difference. This is the atherosclerosis. This is the TAO. So the difference: wall is normal, whereas here wall is thickened. So there is the difference. This is bilateral. Females are less than 10%, actually not even 10%. Some literature is 10%, actually very less. Upper limb can involve, but always lower limb involves first by principle, and then upper limb is involved. Large arteries are usually not involved. That is mainly by atherosclerosis, not by TAO. So these are the pathological differences. Wall is normal, wall is not thickened. Blockage occurs in the lumen, and intimal hyperplasia, they are not in the media. So whereas atherosclerosis is mainly in the media, thickening, cholesterol deposition, all those things. So that is the difference you have to remember. It is not segmental. It is an entire length is not atherosclerosis, whereas TAO is segmental. So these are differences which always remember. It's a panarthritis in a TAO, whereas medium is mainly involved in atherosclerosis. This is the differences you have to remember always between atherosclerosis and TAO. I'm not going to discuss about classification. This is what generalized femoral lower limb, upper limb, and so on. You can always go through it. This is how exactly eventually they'll to gangrene. You know, the gangrene is definition is important. It's MCQ question. Viva they will ask. Short note they will ask. Short note they will ask. Gangrene is defined as macroscopic death of tissue in situ with putrefaction. So that is the definition you remember. You should not grumble about the defining it. In the limb, in the vascular disease, There are two types of gangrene, dry gangrene and wet gangrene. Dry gangrene has got a good line of demarcation, whereas in wet gangrene there is a poor line of demarcation. Line of demarcation is the most important thing. Adequate line of demarcation means dry gangrene, the dry, mummified, no infection. Wet gangrene is progressive proximally, a poor line of demarcation. So there is the difference with you have to remember. Usually there will be hyperemia at the level of the line of demarcation. So landmark for line of demarcation is hyperemia at the level of the line of demarcation. So line of demarcation is the most important. See the line of demarcation is here. See the line of demarcation. See the line of demarcation here. See the gangrene here. See the skip lesion here. This is the skip lesion. This is the skip lesion. See here. See here again dry gangrene here. Like that extensive gangrene here. You can see that entire foot. All these people request a below knee amputation. Below knee amputation. So there is the difference you have to remember. So again dry gangrene, upper limb, lower limb is involved. Both limbs have involved. See the gangrene line of demarcation very clearly. See the both limbs have involved ischemic features in the both limb. See the ulceration. Again ulceration can. So different presentations can occur in these patients. That's what you have to remember. So clinical features, again, I'm not going to detail it. I already told common in males, common in less than 40 years or 45 years. Intermittent claudication initially occurs. It's a Boyd's grading, grade 1. Patients patient after walking, they will have pain, but they continue to walk. All those substance P and lactic acid and other metabolites will get washed out and they continue to walk. Whereas grade 2 is they will have a pain and they will have to take rest, relieve the pain. And grade 3 is they will not continue. They will continue for a few this one, then won't be able to. Whereas rest pain is not a component of Boyd's grading. Remember, rest pain is a totally different. Only 3 grades in the Boyd's grading. Remember, so claudication definitions also you have to remember. Crampy-like pain always appears after exercise, relieved by rest. That is the 3 components of the claudication. Word meaning claudication is claudicare means to limp. Actually, there is a word, technical word, which how claudication has come into the picture. Maybe buttock claudication, maybe leg claudication, maybe foot claudication, occasionally maybe upper limb claudication. So the different levels of claudication are which muscles have involved. Foot, leg is very common. Thigh is common. Occasionally buttock, which is obstruction, is high level, especially that occurs in the atherosclerosis. The TAO mainly in the leg and the foot. So intermittent claudication is a short note. Just to please refer my SRB's manual of surgery, current edition, and SRB's clinical methods of surgery, where it detail about the intermittent claudication, Boyd's grading, everything is given. We can always go through those things and to understand. It's a short note. Viva they will ask, and when you present, it's a long case. Remember, vascular disease is a long case. They will always ask detail about the intermittent claudication, arterial claudication, venous claudication, neurological claudications. So differences they will ask. Please go through my book to understand those things very clearly. And rest pain ulceration is a critical limb ischemia features. So absence and feeble pulse, all peripheral pulses should be written in tabular form, like this, like this. This is the pulse, right, left, dorsalis pedis. From distal to proximal ILOs you have to write, unless there is a specific patient, but the upper limb ischemia as a specific entity, there you write upper limb. Whereas in the lower limb, in other ways, other ischemia, atherosclerosis, TAO, always from the lower limb to upper limb. Dorsalis pedis, posterior tibial, popliteal, femoral, then radial, ulnar, axillary, then subclavian, carotid, superficial temporal. Like that you have to write in tabular form, write present, absent, feeble, plus, present, like that. And always you have to remember all these arteries, where will palpate also. Dorsalis pedis over the navicular bone, posterior tibial over the calcaneum, and popliteal over the portions of the tibia apparent, and femoral artery in the mid-inguinal point, below the mid-inguinal point, between the pubic symphysis and the anterior iliac spine, over the neck of the femur, not head of the femur. Remember, radial artery over the lateral aspect, over the radius, ulnar over the ulnar, and brachial over the bicipital aponeurosis, and axillary or the upper end of the humerus middle aspect, subclavian over the first rib, and carotid over the trisaginar tubercle in the transverse process of the C6 vertebra, and superficial temporal artery is over the zygomatic bone, not over the temporal bone. The temporal bone, there are the branches of the superficial temporal artery, anterior and posterior. It is over the zygomatic bone. So you have to know how to palpate all these vessels, over which bone you have to palpate, and you have to always write in the case sheet in the tabular form, right, left, pulses, dorsalis pedis, posterior tibial, popliteal, femoral, brachial, axillary, subclavian, carotid, superficial temporal artery. Absence feeble pulse, proximal to proximal, distal to proximal, I already told, most important thing. Not proximal to distal unless it is a specific upper limb ischemia as such. May present as Raynaud's phenomena. This is the scoring system for the TAO, remember. Not very popular, but somebody asks in Viva or in MCQs, you can remember all these components are there. Papa et al. Scoring system. Okay, this is the newer scoring system for TAO. So all these things are already told. Skip lesions. It's a progressive gang, spreading probably wet gang. It's a dangerous thing. You may lose the limb. It's a localized actually. Two toes are involved. And pre-gangrene is there. See that? Pre-gangrene is the hyperesthesia will be there in the area. And differential, all these things are the differential diagnosis. Atherosclerosis, vasculitis, other diabetes, renal disease, acrocyanosis, crest syndrome, calcinosis cutis, Raynaud's phenomena, esophageal motility disorder, sclerodactyly, telangiectasia. This is important differential diagnosis. So many things, especially in females, this is common. Trauma is also a differential diagnosis for all this. So I have to remember, the main thing, first and foremost, it's a very common thing, most common thing. You have to remember always this one. And all other things are the differential diagnosis, vasculitis and other things. And investigations in TAO, first thing is non-invasive, arterial Doppler, B mode duplex scan. B is transfer brightness. Another mode for the Doppler is motion mode. That is mainly used for the echocardiography for cardiac system, where here it is a B mode. B mode means bright mode. ABP is a short note for you. Arterial ankle brachial pressure index after placing the 4 BP cups in the both arms above the ankle, then check the blood pressure, ideally through a digital manometry or plethysmography, whatever it is, and then check the difference. And index you have to check, normally above 0.9, and if it is from lesser than that, maybe mild, up to 0.3 it is moderate, below 0.3 it's a critical or severe ABPI, severe ischemia. And if it is very high, that means it is it gives a negative result because calcification is occurred. 13 like that. Calcified vessel is the fallacy of the test. Calcified vessel may not be able to accept the properly. Otherwise, the good index, it's a short note. 0.3 is the critical limb ischemia. Less than 0.3 is the most important thing. Say that limb is critical, may land with the amputation. CT angiogram, dynamic is important. Select and conventional angiogram you have to do if you are doing a angioplasty or stenting, or then conventional angiogram is ideal. Otherwise, CT angiogram for it's the most important. Dynamic CT is the most important thing. In the olden days, we used to do Seldinger's technique, transfemoral, transbrachial, retrograde angiogram. Now, of course, CT angiogram is the most ideal investigation of choice for peripheral vasculitis, especially including TAO. In TAO, we'll see corkscrew appearance, blockage, segmental back blockage, corkscrew appearance, peripheral collateral circulation, and distal runoff. Distal runoff is the most important. This corkscrew appearance is very typical of the TAO actually. Distal runoff says if there is adequate distal runoff in angiogram, that means it is a compensated peripheral vasculitis. You are happy, but important thing, stop smoking, give drugs for improve the circulation. And stop smoking is the most important thing. And if there is a blockage, poor distal runoff, no collaterals, that's a decompensated peripheral vasculitis, it's a critical limb ischemia. Mostly patient land with amputation of different levels, but still revascularization procedure like graft, cephalosporin graft, or synthetic graft, or endarterectomy, thrombectomy, all those things can be done. Fundoplasty, where superficial femoral artery and defemoral artery junction is blocked, where if you remove that block and put a small venous patch or synthetic graft. So improve the profunda femoris perfusion. Profunda femoris is the mainly maintains the collaterals of the limb. So improve the collaterals through the profunda femoris. Profunda plast it is called as. Then you will be able to revascularize the limb and save the limb. Salvaging, you can salvage the limb. So all those different surgical techniques you should remember. Ultrasound abdomen is important because aneurysm may be there in this patient, especially with elderly patient. Blood sugar, lipid profile, all the things are to rule out other things. Now currently intravenous ultrasound, intravascular ultrasound, not venous, sorry, intravascular means arterial ultrasound will be able to see sound waves and find out where exactly, so very clearly will be able to see where exactly. The newer thing, IVUS, intravascular ultrasound, specifically the arterial ultrasound. So you can put the ultrasound and probe inside that and assess where exactly this blockage is, and then it's a very, very good investigation. Skin perfusion pressure test is the mainly to the skin perfusion. Skin perfusions again important. It's mainly see the red cell motility. So it's very final actually. How much perfusion is good, whether the tissue is hypoxic or not, especially in the skin area, mainly skin area. So that will give the very clear idea about the perfusion and of the part and as a whole. So this is important newer test, but very useful. So all these things are should be looked for. I already told blockage, cork inverted tree or spider leg, corrugated rippled artery. Distal run is the most important. See that this is the blockage here. So that this is the narrowing here, but perfusion is there. See the blockage here. See the collaterals here. All these things are the collaterals. So good collaterals, better to the limb. Will be able to save the limb. Collaterals also blocked along with the main vessel. As a poor, limb will not be able to save. Eventually, they will land with the amputation. So all these things are there in my SRB manual of surgery, arterial disease, and clinical method of surgery, arterial disease, arterial examination. So you can go through those things and learn in detail about the TAO. So these are exactly intravascular ultrasound return. Probe is there, fine probe. See that? It goes inside and gives the image whether atherosclerotic flake is there or not. Very, very newer technique, innovative technique. So again, this is the skin perfusion test. It assists the red cell motility. That is the most important principle. So this is related to the microcirculation. So what you are assessing is microcirculation. So that is finally at the end of the day, microcirculation is the one which provides the perfusion to any part of the body. It has got arteriole, it has got a venule, in between capillary, arteriole, venule, here capillaries. That is the microcirculation. So finally, microcirculation is the most important thing. So we assess the microcirculation of the area. That will give the very clear idea. It's a very beautiful test actually. So these are the instruments, and this is the normal pressure perfusion test. And when it becomes critical ischemia with these different pressures actually. Normally 50 to 100, 50 to 30, marginal, less than 30 is critical. So treatment, most important is stop smoking, stop smoking. Either you will have a smoke or limb. You cannot have both. If you don't stop smoking, you will lose the limb. If you want to have a limb, you have to stop smoking. That is the most important thing you have to remember. Aspirin is important, this is the blood. These are the different drugs. Most commonly used drug is xylostazole to improve the perfusion. All drugs, remember, at the collateral level. Because main vessel is totally diseased. This is the main vessel. This is completely diseased. So nothing will act. It's totally blocked, occlusion. And these collaterals, all these drugs act over these collaterals. And other than that, analgesic, all those things all can be given. Intravenous iloprost, prostaglandin analog, costly but said to be very, very useful to improve the perfusion. I used to do in few patients. It has really helped. But whether it will be helpful to every patient, we don't know. We can always say try. But cost factor is important thing you have to remember. Otherwise, said to be very, very useful currently, iloprost. So xanthine nicotinamide injection also useful. Daily you have to give first day and 5 day. Low molecular dextran also quite useful. This is the trial, it increases the perfusion. Definitely, so certain extent they are useful. In a severe cases, Hyperbaric oxygen, that is also quite useful. You can have a trial of saving the limb by hyperbaric oxygen, but you can't give a 100% result. It's only trial. You may be able to save the limb, but only trial. Remember, most of the people, only few percentage of people will be able to save the limb. Because finally, perfusion, which is most important rather than anything. Gene therapy is said to be very useful, but costly. It's a under trial. Eventually, it may come into the picture. Remember, vasodilators, anticoagulants, drugs like pentoxifylline have been used for a long time, but its efficacy is not that good actually. Rather, this is said to be useful for the venous disease and venous ulcer than arterial disease. Remember, it is said to pentoxifylline increases the flexibility of the RBC. So RBC like this, and it becomes like this. So it squeezes in a narrowed vessel. That is what is the concept as far as pentoxifylline is concerned. But it's said now currently it is more useful for the venous ulcer than arterial disease. So care of the limb and feet, BUERGE'S position and exercise. These are the things. Limb elevation, reduce. All those exercises are important to improve the circulation. This is most important. This is how exactly we will do the exercise. Legs elevated to 45 degree and kept for 2 minutes. Kept elevated, then again reduce. Kept elevated, 2 minutes, reduce. Like that. Different methods are there, like it is mentioned. BUERGE'S exercise. For BUERGE'S disease, BUERGE'S position, BUERGE'S exercise. Most important. And avoiding injury, that's important. Trauma should be avoided. Even nail paring. Exposure to the feet to the cold and warm. It will cause definitely skin changes and may cause infection. Although if there is poor perfusion, may go lead to the gangrene. So care of the foot and leg is most important. Dryness should be avoided. Apply oil. This is important. Always apply oil almost daily for any peripheral vascular disease. Footwear, MCR chappals or some other specific medical related chappals, soft chappals, so that pressure source will not occur under the foot. So that will lead to the infection and skin loss and so on. Wear socks with the foot or heel raising may be helpful. Heel raise around 2 centimeter. It will increase the perfusion. So all these precautions has to be taken as far as feet is concerned. Trauma, most of trauma, avoid dryness. This is the most important thing. So this is the newer thing. Remember, autologous bone marrow may be helpful. Endovascular therapy, PTA, like what we do for the atherosclerosis, is helpful for TAO. Chemical sympathectomy. So severe pain, you can do a sympathectomy by a sympathetic blockage under C-arm guidance to L2, 3, 4 sympathetic chain. So it's also helpful in severe pain where they land with the amputation. That is the most thing you have to remember. Omentoplasty is said to be very useful. Pedicle omentum is harvested, usually right gastroepiploic artery. You get a very length like this, and that tube should be passed under the subcutaneous plane. Channel it up to you can reach up to the middle of the leg or up to the ankle, and open the deep fascia and connect there. You'll be able to reperfuse. Very good procedure actually. No, though not commonly done. Very simple, easier. Any general surgeon can do it. May reperfuse and save the limb, reduce the pain, prevent the further ischemia. But of course, patient should stop the smoking. That's the most important thing. So profoundoplasty, I already told. Arterial surgeries like endarterectomy, thrombectomy, arterial graft using great saphenous vein, sympathectomy procedure as such. It's a temporary, but increases skin perfusion so that it makes the ulcer to heal, mainly for ulcer. Elizarov technique is by bone lengthening improves the circulation. It's said to be quite useful, but not commonly done, technically demanding. Of course, eventually amputation. If there is a gangrene, that tissue has to come out. You won't be able to save. You have to be very, very clear with the patient. They'll try to save that foot, save the leg and foot. Once it's dead, like gangrene, whatever I shown in the pitch for earlier features, it has to come out. Toe amputation, below knee amputation, above knee amputation. You straight away to tell this is dead tissue, you can't save it. Then you should be very clear about those points. This is the newer thing, angiosome concept. It is said that certain specific areas of the skin of the body will have specific blood supply. They are called angiosomes. Usually around 40 angiosomes are there, like whatever it is mentioned here. And those specific angiosomes, if you're able to identify, and you'll be able to filter, you'll be able to get blood supply from this angiosome. Suppose one angiosome has got blood supply, next angiosome doesn't have blood supply. Then if you're able to get a connection, you'll be able to save the limb. There is an angiosome concept. See that totally 40 angiosomes are there. Maybe MCQ question. In lower limb, 6 angiosomes. All these things are there. Along the posterior tibial artery, medial lateral plantar artery, what the instep and this one, and along the anterior tibial artery, and 2 along the peroneal artery, and 1 is the calcaneal mesh. So the 6 in the lower limb, total 46 in the lower limb, 46 in the lower limb, and each is connected to each other through a choke artery. This is the one angiosome, this is the one angiosome. 6 are there, 1, 2, 3, 4, 5, 6, and this is connected to each other by what is called a choke artery vessels to maintain blood supply. Particular angiosome, it is system critical. If this angiosome is critical, then other angiosome choke vessel will open up. It's connected by choke vessel, and like a vehicle, there is a choke. If there is a vehicle got it stops, then you can choke it and start again. There is a concept there. Same thing. This blood supply is poor. This is adequate, means there is a choke vessel which opens up and perfuse. There is a connection. So this is called choke vessel. It's important concept and maintains the blood supply. That ischemic angiosome from the adjacent angiosome. So ischemic angiosome, normal angiosomes connected by choke vessel maintain the perfusion. That's the newer concept, angiosome concept. Similarly, there is a venosome also. I'm not going to discuss that. So remember, this is most important. Angiitis, AITI, double I. Spelling I just want to. Also called as BUERGE'S disease. It's a very common long case asked. Main question in the theory. And 3 short course of the treatment of TAO, investigation of TAO, clinical features of TAO. It will be asked. Lot of MCQs will be asked. Oxy they will ask. They'll write one question. Classify intermittent claudication like that. So you should be able to give an answer. Boyd's grading, you should have 3 grading. Rest by critical limb ischemia is important thing. Functional limb ischemia, pathology is important. Differences between atherosclerosis and the TAO, I already told. One is segmental, one is this one. Vessel wall is normal, vessel wall is thickened in atherosclerosis, segmental, larger vessels, medium sized vessels. So all these things will be asked in the MCQs, you should remember. And lower limb is commonly ignored. Classifications you have to remember. And smoking is the most important thing. And HNO classification for BUERGE'S disease is another classification. Tobacco use, only males. Disease starts before 45 years. I already told. Distal estimation is not first. Already told all these things. Smoke year index. This is also will be asked in the Viva, MCQs, when you present a long case also. Number of years of smoking to number of cigarettes smoked per year. Pack year index, number of years of smoking. Here number of cigarettes, here number of packets. That's the difference. Smoke number of years of smoking is same. These are the same. Where number of cigarettes smoking is smoke year index. Number of packets smoked is pack year index. Distal runoff is very important in angiogram. Stop smoking. That is the most important thing. Drugs like arterial devascularization with the Gertz vein or arterial grafts. It's important. This is the point which you have to remember. Smokers, most common. Young age smoker, below 45. Differentiate that is atherosclerosis, vascular, all those things. So TAO is a very common long case, theory question, MCQs. Students, please read my SRB manual surgery, vascular arterial disease. It is given in detail about everything, whatever you want to know, even including angiosome concept and other things, newer methods also. And it's a long case also. MCQs will be asked. MCQs are there in my current edition book. The separate booklet has come. You can read that. And please subscribe my website, SRB's surgical website and YouTube channel. And it's free. Daily you can learn different from the instruments, operative surgery. Already more than 450 videos, lectures are there. Short cases, long cases, instruments, case presentations. There are so many live sessions. It's already there last 2 years. You can go through that so that students can learn surgery on day-to-day basis. It will be interesting. And also you can join my live sessions once in 2 weeks and so on, which happens. It will be last usually 1.5 to 2 hours. Student will present, undergraduate student will present. Different senior faculty other than including me will be there to discuss and how to present. So that will be very, very useful for your exam. And facing a surgery theory, oxy, and clinical also. And much more than that, you will learn surgery in an interesting way and proper way. And MCQs are there in almost at regular, usually daily or at regular intervals. Already a lot of MCQs are there in my YouTube channel. You can always go through that and enjoy that MCQs. It will be very, very useful to answer in your exam, and also it will be useful to answer eventually in your when you go and go for the entrance exam for postgraduate students. Again, a request: please subscribe my YouTube channel, and my DigiNow lectures are there through JP. You can subscribe for 1 year and learn surgery entire thing. Go through my SRB's manual surgery with the MCQ there along with that small booklet. It gives everything about all topics as far as CBSE syllabus is concerned. It will be very, very useful to learn. Current edition has come out very well. It gives a lot of information, makes surgery learning very interesting. My clinical method surgery is gives proper method of exams in all cases: arterial disease, venous disease, then hernia, hydrocele, ulcer, swelling. Of course, with the video there, how to examine with the differential diagnosis. But there is no treatment in the clinical methods. Instruments are there, specimens are there. Again, please go through that. It will be very, very useful. So students, I hope you have understood topic TAO. It's very, very important for you very well. So before telling, thank you so much. Again, subscribe my YouTube channel, share that with your friends and colleagues, and daily go through the lectures to learn surgery better. And also go through my manual of surgery and clinical method of surgery to learn surgery perfectly as such. Thank you so much.